Hello, I'm Dr. Hagop Kantarjian from the MD Anderson Cancer Center, and it's my pleasure to interview Dr. Mark Litzow from the Mayo Clinic in this SOHO meeting 2024. So Dr. Litzow had an amazing new publication in the New England Journal of Medicine about the role of blinatumomab in adults with acute lymphocytic leukemia who are in MRD-negative remission and randomized to blinatumomab or standard of care. So, Dr. Litzow, I'd like to ask you about this study, and then we can talk about the role of immunotherapy. So can you tell us a little bit about the design of the study, how it was conducted, and what were the results?
Thank you, Dr. Kantarjian. So this was the ECOG E1910 clinical trial. We enrolled 488 patients between the ages of 30 and 70 with B-cell precursor Philadelphia chromosome negative acute lymphoblastic leukemia. We gave them induction chemotherapy for 2.5 months, and if they achieved a conventional morphologic complete remission, they continued on study and then received an intensification for CNS prophylaxis with high-dose methotrexate. And then at that point, their clinical status was assessed, and if they were in remission and MRD negative, we then randomized them to receive standard consolidation chemotherapy with 4 cycles of treatment and then on to maintenance therapy. Patients could go off to an allogeneic transplant if the investigator felt that was in their best interests. On the experimental arm, patients received that same 4 cycles of consolidation chemotherapy, but we gave 4 4-week cycles of blinatumomab by continuous infusion, 2 cycles initially, then 3 cycles of chemotherapy, then another cycle of blinatumomab, another cycle of chemotherapy, the 4th cycle of blinatumomab, and then on to maintenance therapy. So of the 488 patients that we enrolled, 81% of them achieved a complete remission. They then, the patients that got to the randomization were 224 patients who were MRD negative, and there were 112 in each arm of the study, and we showed that at 3 years, the patients that received blinatumomab plus chemotherapy had an 85% overall survival compared to 68% in the chemotherapy arm, and this was from the time of the randomization. So we were quite encouraged by that result. We saw similar results for relapse-free survival. We saw more benefit in patients under the age of 55 compared to those over the age of 55. The treatment seemed to benefit patients, though, both with favorable combined molecular genetic risk, whether they had a favorable risk or whether they had unfavorable genetics. So we felt that this represents a new standard of care to add blinatumomab to the treatment of patients with MRD-negative remission, and it led the Food and Drug Administration to approve blinatumomab for use in consolidation therapy just in June of this year.
And I noticed that in the study, not all the patients were able to receive the 4 courses of the blinatumomab. What was the reason? Was it because they went to transplant, or did you observe any toxicities that would not allow completion of the 4 courses?
We did. Now, the patients on the blinatumomab arm, if the investigator wished to take them off to transplant, then they only did receive 2 cycles. So some patients that went to transplant, but that was 20% of the patients. Other patients did have some toxicity. We did see more neuropsychiatric events in the blinatumomab arm of the study, and so that led to some discontinuation. There were some relapses, so patients didn't complete all 4 cycles. So it was a mix of reasons. 80% of the patients did receive at least 2 cycles.
Okay. And one more question about the neurotoxicity. Was this age-related, and are there any mitigating strategies to prevent or reduce the risk of the neurotoxicities or the cytokine release syndrome problem?
There was little or no cytokine release syndrome. These were patients that were all in remission when they received the blinatumomab. I honestly don't have data on the age breakdown of the neuropsychiatric events, so I can't say whether it was more common in older individuals. I don't have any unique mitigating strategies for dealing with that. I mean, the patients all received some steroids before they got the blinatumomab, but that's an important question.
So if I can ask the question on the causes of relapse. So the 3-year survival on the blinatumomab investigational arm was 85%. You cannot beat that. But for the patients who failed, was the failure from relapse, or were there any induction mortality, were there any mortalities on the investigational arm that were unusual?
None that were unusual, but there were some non-relapse mortality on the blinatumomab arm, and a lot of that related to the chemotherapy cycles that they received. So neutropenic deaths, infection, some organ toxicity, but that was more related, I think, to the chemotherapy rather than to the blinatumomab. And there were about equal numbers of non-relapse mortality in each arm, and the difference in the deaths was the increased relapses in the chemotherapy arm.
And do you remember the incidence of relapses on the blina versus the control arm cumulatively?
Well, there were 40 deaths on the chemotherapy arm, and 31 of those were from relapse. There were 17 deaths on the blinatumomab arm, and 8 of them were from relapse.
So a very low relapse rate on the blina. But if you had to design the study, would you say that we need to try to get all 4 courses of the blinatumomab, or do you think 2 may be enough? What is the ideal number of blinatumomab courses? Because I noticed in an infant study in children or in infants with KMT2A-ALL, which is a very refractory one, they gave just 1 course of the blinatumomab, and those infants had a 2-year survival jump from 50 to 90%. So what is the optimal number of blinatumomab doses, courses in adults, you think?
Well, I can't definitively say. We've tried to see if we could look at, say, 2 cycles versus 4 cycles, but that analysis is problematic because some of the patients only got 2 cycles because of transplant, and there were a lot of mitigating factors. So I've been telling people that it's best to try to get 4 in, but it may be, well, that 2 is enough.
And one more question. I noticed that you started with 488 patients, but 224 were randomized. So to prevent this loss from the denominator, what would be your thinking about a future study in ALL?
Well, I think the message, and certainly the studies that you have done at MD Anderson, would support bringing immunotherapy earlier into the course of the treatment, given its efficacy and lower toxicity. Certainly, I think that our goal in ALL is to rely more on immunotherapy and lessen the chemotherapy, particularly in older individuals who do not tolerate it well.
So today we have several immunotherapy tools. We have the blinatumomab to target CD19, the inotuzumab to target CD22, and then the CAR T cells, which people are talking about bringing earlier into first complete remission. What is your thinking about an ideal regimen in ALL? So if you were to look at your crystal ball and say 5 years from now, this is what I think adult ALL therapy would be, how would you design a study that would get us there?
Yes. Well, there's been more data, I think, using inotuzumab initially in induction. The Germans did the initial 1 trial in patients over the age of 55, where they gave 3 cycles of inotuzumab and had a high remission rate, and then one got on chemotherapy. The Alliance did the trial in elderly patients with inotuzumab and blinatumomab alone. So I don't know that they have to use inotuzumab first, but I think that seems like a reasonable way to approach it, and then use blinatumomab more in a consolidative phase. If patients are remaining persistently MRD positive, I think that would be an ideal situation to bring in CAR T-cell therapy.
So a lot of people are talking about the CAR T-cells, and initially the approval is in relapse with active disease, and the experts say that you need some leukemia to allow the expansion of the CAR T-cells. If we bring the CAR T-cells to first remission where the amount of disease is much less, would that be beneficial? How do we balance the amount of leukemia that's left to stimulate the CAR T-cells to expand versus too much leukemia where the CAR T-cells may not work as well?
Yeah. Well, I think the MRD positive setting where there's less than 5% blasts but still evidence of disease by MRD is the ideal setting to further test the CAR T-cell. And we've seen the CAR T-cells have efficacy already in that setting. So I think that would be the ideal place to look next. I think I would do that first before, say, considering giving CAR T-cell therapy to an MRD-negative patient.
Thank you very much, Dr. Litzow, and congratulations on this very big discovery in adult acute lymphocytic leukemia.
Well, thank you very much.